Hello, everyone. My name is Gurjot Basra, and I'm the Manager of Patient Programs, Research, and Advocacy here at Lymphoma Canada. I'm pleased to welcome you all to the final live session of the day titled Targeted Therapies, including BTKis and bispecific antibodies. So just before we start, like I mentioned in the previous sessions, I just want to go over the housekeeping items. So this includes the Zoom software does not allow you to access your camera or your microphone. So if you do have a question, please be sure to enter it in the chat below. And additionally, this webinar will be recorded and it will be available on our website shortly after the conference. And you will also receive an email notification with the links to access these recordings. So with that said, to introduce our speaker today, we have here Dr. Robert Puckrin, who is a hematologist and staff physician in the Alberta Blood and Marrow Transplant Program at the University of Calgary, with interest in lymphoma, CAR T-cell therapy, stem cell transplantation, and clinical research. So thank you, Dr. Puckrin, for joining us today, and you can get started as soon as you're ready.
All right, well, thank you very much. I'm very happy to be here with you all this afternoon. So we have an exciting topic this afternoon. We'll be talking about some innovative new treatments for lymphoma as well as for chronic lymphocytic leukemia. These are targeted treatments and new immune treatments in some cases. They go by the names of BTK inhibitors, BCL2 inhibitors, and bispecific antibodies. So we'll tackle each one at a time, go over how these drugs are used. There are 5 main pillars of cancer treatment. Some have been around for much longer than others, but they all still play a very important role in treating cancer to this day. Surgery was the earliest treatment for cancer that's been practiced since ancient times. That's a very important treatment for curing many cancers, especially when they're localized to just one area. But in many cases, such as blood cancers, for example, they tend to be more widespread throughout the blood or the body and aren't always treatable by surgery. In the late 1800s, radiation therapy was developed. Here we can actually target tumor cells with radiation beams, and they can be very effective at killing off certain types of cancer. In the 1940s, chemotherapy was developed. So chemotherapy technically refers to chemicals that basically kill off any quickly dividing cell in the body. So cancer cells are usually quickly dividing, so they often are killed off by chemotherapy. But chemotherapy isn't particularly precise, and it can also kill off other quickly growing cells in the body, including the hair follicles, which can cause the hair to fall out. It can also affect the bone marrow and cause the blood counts to drop low, which can increase the risk of infections. And it can also affect the mouth and the bowels, which can lead to nausea or sometimes mouth sores or diarrhea. So chemotherapy is very effective against a number of cancers, in particular lymphoma, but it can cause some of those side effects because of its effects on other parts of the body. Over the past few decades, there really has been a number of very exciting breakthroughs in understanding cancer on a deeper, more scientific level, right down to the very genes and mutations that are involved in causing cancers to grow. And some of these scientific breakthroughs have led to new treatments that target the cancer on that more precise biology level. So instead of just killing off any quickly growing cell in the body, we can actually train our treatments to target certain weak points or certain mutations that are present in the cancer. So that's what a targeted therapy is. It's really a precision type of medicine that's targeted towards the cancer. Immunotherapy is very similar, but these are targeted drugs that help to activate the patient's own immune system to start to attack and eradicate the cancer. And there have been a number of very important medicines from these 2 pillars that have become more and more widely used in the treatment of lymphoma and leukemia over the past years. So one of the first very important targeted drugs that has become available over the past 10 years is a class of medicines called BTK inhibitors. So BTK refers to Bruton's tyrosine kinase. So this is a protein that is expressed on the surface of many cancerous B cells. And B cells are the most common type of cancer that are affected in lymphomas as well as leukemias like chronic lymphocytic leukemia. The cancerous B cells have this receptor on the surface that causes the cancerous B cell to quickly grow and divide and makes the tumor grow out of control, and BTK is one of the important proteins in that receptor. Thanks to our better understanding of how this protein causes these cancer cells to grow, scientists were able to develop new medicines that specifically inhibit that protein or block that protein from having its effect. And that then shuts down this whole process and prevents the cancerous cell from growing out of control. The first BTK inhibitor that became available was a medicine called ibrutinib. So this is a treatment that's taken by mouth as tablets, and the typical dose for chronic lymphocytic leukemia is 420 milligrams, which is about 3 tablets taken once every day. For mantle cell lymphoma, the typical dose is 560 milligrams or 4 tablets, also taken once per day. Over the past few years, a second generation of these medicines has become available in Canada and around the world. These are 2 new medicines called acalabrutinib and zanubrutinib. They both have been compared directly to ibrutinib. These drugs all work in a very similar way. Acalabrutinib and zanubrutinib are both equally effective as ibrutinib, but what makes these 2 medicines advantageous is that they tend to be better targeted, so they have fewer side effects than ibrutinib. So that makes both of these medicines a more common choice nowadays because they come with lower risks of side effects. Acalabrutinib is taken by mouth as a tablet, 100 milligram or 1 tablet 2 times per day. With zanubrutinib, patients have a couple of options. They can take it as 320 milligrams or 4 tablets once per day, or alternatively, they can divide it up and take 160 milligrams or 2 tablets in the morning, and then again 2 tablets in the evening. So when do we currently use BTK inhibitors in Canada? So ibrutinib, acalabrutinib, and zanubrutinib are currently approved by Health Canada and funded in most provinces for chronic lymphocytic leukemia. We can use it as the first treatment of the disease for patients who have higher risk leukemia, and that's typically defined by having 1 or 2 genetic mutations that can make the leukemia less responsive to chemotherapy. So one of those mutations is called chromosome 17p. The other one is called IGHV. If it's unmutated, then that means that the disease may not respond as well to chemotherapy, but it can respond very, very well to these targeted treatments instead. And then we can also use these tablets for patients who have previously received treatment for their CLL. For example, they received chemotherapy in the past, but then the disease relapsed or started to grow again and required treatment. Ibrutinib is also approved for mantle cell lymphoma in cases of relapse when a patient has already received a previous treatment and the disease has become active again. And recently, zanubrutinib also became available for a less common lymphoma, Waldenstrom's macroglobulinemia, if it has relapsed after a previous treatment. So these medicines are clearly showing a lot of promising activity in a variety of different diseases. So how long do we give these medicines for? So as we mentioned, we typically give these medicines every single day, and they're designed to be taken indefinitely, meaning that we continue the treatment for as long as it's working, for as long as the cancer remains in remission, or in some cases, we may have to stop the treatment early if the patient develops bad side effects of the medicine, although that's not very common. So in the clinical trials, they compared these medicines to chemotherapy and found these medicines were much more effective. As the first treatment of CLL, ibrutinib was able to actually control the disease for, on average, about 10 years. So in most cases, the leukemia eventually does become resistant to ibrutinib, but these drugs do tend to work for quite a long time. And most people who start these medicines can expect to be on these medicines and benefiting from their activity for many years on average. One interesting thing about how these medicines work is that they first shrink down the lymph nodes and help to clear the cancerous cells from the lymph nodes and the bone marrow and move them into the bloodstream. So it's actually quite common during the first few weeks after starting the treatment to see the lymph node shrink down. And that's shown here in the yellow line, where the lymph nodes decrease in size from their baseline. But what happens when the cancerous cells move from the lymph nodes into the bloodstream is that we can see a significant increase in the cancerous cells in the blood. And we often measure that with the lymphocyte count. And that can actually often shoot up quite high during the first few weeks after the treatment is started. So that can be quite unexpected for some patients. They might look at their blood work and see their white blood cells or the lymphocytes are increasing rapidly, and they might worry that the treatment isn't working. But actually, it's a very good sign that the treatment is working. It's shrinking down the lymph nodes, it's moving the lymphocytes into the bloodstream, and then those cancerous cells eventually do die off. And usually after the first few months, the lymphocytes return down to normal, and the disease continues to remain in remission after that. So that's one interesting thing to watch out for when starting these medicines. In general, BTK inhibitors are actually quite well tolerated. Many patients take these pills every day for many years and feel pretty much completely normal. Sometimes they might even forget that they're actually receiving cancer treatment because these treatments are so well targeted and typically don't cause too many side effects. But like any medicine, they can cause some side effects in some people, and it can vary from person to person. Some of the common ones that we can run into include headaches, and that's usually just during the first few weeks of treatment. They typically go away after that, and they usually respond well to drinking lots of fluids, taking Tylenol, or having caffeine like some coffee or tea. Some patients can also experience muscle aches or joint aches from these medicines. We can often manage that with some Tylenol, or some stretching, some light activity. In some cases, we have to reduce the dose a little bit to help it to agree better with the person's body. In some cases, these medicines can also cause low blood counts and increase the risk of infections, although because they are better targeted, they tend not to be as immune suppressive as chemotherapy. So we tend not to see as low blood counts or as high a risk of infections as we can with chemo. These medicines do block the platelets, so they work a little bit like aspirin, and that can lead to easy bruising. So some people might notice easy bruises on their arms or legs, for example. In rare cases, there can also be bleeding that occurs. So it is important if you are on a BTK inhibitor to hold it for sometimes up to a week before or after any surgery to help prevent any risk of bleeding with the surgery. The medicine can also sometimes cause rashes or changes to the nails. We can often manage that with ointments or skin creams, or biotin supplements might help with the nail changes. And then some people can get an upset stomach or diarrhea from these medicines. That we can often manage by either reducing the dose temporarily or taking it at bedtime. One particular type of side effect to watch out for are cardiac or heart side effects. So in some cases, these medicines can affect the heart and cause an electrical disturbance or an arrhythmia called atrial fibrillation. This arrhythmia is actually fairly common in the population as people get older, but the risk can be increased if you're on one of these pills. Some patients might experience this as symptoms like palpitations or racing heart, skipped beats, or sometimes even dizziness or fainting spells. Some people also can develop high blood pressure while they're on this medicine, and that can require additional monitoring and treatment to control the blood pressure. And there have been very rare reports of people who have actually developed fatal arrhythmias as a result of this medicine, particularly if they have severe underlying heart disease. That's quite rare in otherwise healthy people. So this is something that we have to watch out for while on this medicine. If these heart disturbances do occur, then they may require being seen by a cardiologist or starting new medicines to help control the heart rate. But the risk of that is generally quite low, particularly with the second generation of BTK inhibitors, the acalabrutinib or zanubrutinib. We see far fewer heart side effects than we do with the original medicine ibrutinib. So what are some practical points to remember when taking a BTK inhibitor? Because these are pills that need to be taken every day over the long term for them to work, it is important to set a reminder so that you don't forget to take it. If you do experience any side effects, you can chat about that with your healthcare team and your doctor. Most of the side effects are usually manageable. We can often address them by reducing the dose or holding the dose temporarily. And most people, or sometimes we can switch the drug to a different one. And most people do well with that approach. As I mentioned, there is that risk of bleeding and bruising, so we try to avoid combining these medicines with strong blood thinners like a warfarin. It's important to hold it before or after any surgery that you might need to have done. And it is important to remember that these medicines can also interact with other drugs and sometimes even interact with herbal supplements that can cause the drugs to become more or less effective or sometimes increase the risk of side effects. So if you are starting any other new medicine, like an antibiotic, for example, it's important to run it by your pharmacist just to make sure it doesn't interfere with the BTK inhibitor. So that brings us to our next class of targeted treatments, which are called BCL2 inhibitors. So BCL2 is also a protein that is found within cancerous B cells, including lymphomas and chronic lymphocytic leukemia. BCL2 is a protein that actually prevents the cancer cell from dying off. So many cancers have high levels of BCL2, which allows the cancer to continue living and continue growing. So BCL2 inhibitors are small drugs that are targeted to that specific molecule. They block BCL2, and that leads the cancer cell to die off. So they work a little bit differently from BTK inhibitors. BTK inhibitors prevent the cancer cell from growing, whereas BCL2 inhibitors cause the cancer cell to die off. We currently only have one BCL2 inhibitor approved and available in Canada, but there are other ones that are in development and on the way in clinical trials. So the one we currently have is called venetoclax. This is also a tablet taken by mouth. The typical dose is 400 milligrams or 4 tablets once every day. Currently in the lymphoma world, venetoclax is used for chronic lymphocytic leukemia. It can be used as the first treatment of patients who are not eligible for intensive chemotherapy. That's usually due to older age or other medical problems. And it can also be used for the treatment of CLL, which has relapsed after a previous treatment. Venetoclax is given differently from BTK inhibitors. So we mentioned that BTK inhibitors are typically given indefinitely over the long term for many years, for as long as they're working and not causing any side effects. Venetoclax is typically given for a fixed duration, which means that we typically give it for 1 year or 2 years, and then we get to stop the treatment. Usually the disease will remain in remission for many years after that, and the patient can then benefit from that nice long remission without having to take a pill every day. We often combine venetoclax with an antibody treatment, like rituximab or obinutuzumab. So these are antibodies that are targeted to the cancerous B cell, and they help to activate the immune system to attack the cancer cell. So these antibodies are a form of immune therapy, and we find that by combining the venetoclax, the targeted treatment, with the antibody, the immune therapy, we can achieve even longer remissions. The antibody treatment is typically given intravenously or in some cases as an injection under the skin, whereas the venetoclax is taken by mouth. And the exact duration of treatment depends a little bit on which protocol we're following. So for the first treatment of CLL, we combine venetoclax with a obinutuzumab antibody, and that's typically 1 year of treatment, followed by a very nice long remission that typically lasts for at least 5 years or longer. For patients who have already received treatment for CLL in the past and they now have relapse and need a new treatment, we give venetoclax with rituximab, and the venetoclax in this case is given over a 2-year period. The antibody treatments are just given during the first 6 months. Some patients in some cases may receive venetoclax in a different way. They might take it similar to the way that we give a BTK inhibitor every day over the long term for as long as the drug is working and not causing too many side effects. So this might depend a little bit on each person's situation, and that can be discussed with their physician. But oftentimes it is just 1 or 2 years of treatment, and then the patient does get to stop. So BCL2 inhibitors can cause some side effects, although most people actually feel pretty normal while they're taking it. The most important side effect to be mindful of is something called tumor lysis syndrome. So this is actually quite interesting. The main risk of the drug is that it can work so well that if we're not careful and we just gave the full dose of the drug without any monitoring, it could actually be dangerous because the medicine can kill off the CLL cells very quickly. And when the CLL cells die, they can release all of these electrolytes into the bloodstream, like potassium and calcium and phosphorus. And too much of these electrolytes can actually be dangerous. They can damage the kidney, they can cause heart problems, or they can cause weakness or rarely even seizures. So to help reduce this risk, we have a very careful monitoring protocol where we start with a baby dose of the venetoclax and then we slowly increase it week by week. And usually by following that protocol and monitoring closely, we can prevent any tumor lysis syndrome from happening. And most patients do get through it very smoothly and safely as a result. That side effect of tumor lysis syndrome typically just occurs at the beginning during the first month or so of treatment. After that, the main side effects that we have to watch out for can be low blood counts and infections. So we do have to monitor the blood work every few weeks or every few months during treatment. But again, these medicines aren't as immune suppressive as chemo, so the risk of infections and low blood counts is lower. Some people can get stomach upset or loose stools as a result of this medication, but that can usually be managed with Imodium or reducing the dose in some cases. And then just like BTK inhibitors, these medicines can have interactions with other medicines. So it's important to check with your pharmacist if you are starting a new pill to make sure it doesn't interfere. This diagram here shows how the medicine is given. So as the first treatment of CLL, we combine venetoclax with the antibody obinutuzumab. The antibody is given intravenously. We give 4 doses over the first couple of weeks, and that's designed to help shrink down the CLL to a low level to help reduce the risk of tumor lysis syndrome. After those first 4 doses, the antibody is then given once a month for 6 months, and then there's no more intravenous treatment. The venetoclax, the tablets, they typically start at the 3-week mark once the patient has already finished 4 of the antibody treatments. We start with a very small dose of the venetoclax, only 20 milligrams. We take that every day for a week, and then each week we slowly increase the dose up to 50 milligrams, 100 milligrams, 200 milligrams, and then finally after a month, we reach the full dose of 400 milligrams. So by slowly increasing the dose, we can make sure that the drug gets into the system safely and the risk of tumor lysis syndrome goes down quite a lot as a result. After that first month, patients then take the full dose, 400 milligrams every day for the 1 year, and then they get to stop. We have to monitor very carefully for tumor lysis syndrome during that first month when we're increasing the dose of the venetoclax. It's important to determine if a person is at high or low risk of tumor lysis at the beginning of treatment. So patients who are at high risk of tumor lysis have very big lymph nodes, bigger than 10 centimeters, or they might have lymph nodes that are bigger than 5 centimeters, along with a lymphocyte count or a CLL count in the blood that's greater than 25. If either of these risk factors is present, then these patients will need a lot of hydration to help flush the electrolytes out of their body, as well as intravenous fluids to help protect the kidneys. We'll often give a medicine called allopurinol during that first month to help prevent tumor lysis syndrome. And there's also lots of blood work monitoring during that first month. So high-risk patients may actually need to be admitted to hospital for 24 hours to receive the first dose, and then a week later at the higher dose. And then there's frequent blood work while in hospital to monitor the electrolytes. After the first 2 weeks, the rest of the treatment can be done as an outpatient, but there needs to be blood work done about 3 times a week before we increase the dose, 8 hours after the dose is increased, and then 24 hours after the dose is increased to monitor the electrolytes. Most patients don't end up being in that high-risk category because they receive the obinutuzumab, the antibody, beforehand to help shrink down the disease. So most people actually have small lymph nodes and a low lymphocyte count, and as a result, they're at low risk of tumor lysis syndrome when it comes time to start the venetoclax. So in these cases, most people don't need to be admitted to the hospital. It still is important to drink lots of water to help keep the kidneys happy. And it still is important to do blood work testing, but it's not quite as often. So for the first 2 weeks, patients do need to do blood work before the dose, 6 to 8 hours after the dose increase, and then 24 hours after the dose increase. We do that for the first week and then again for the second week. And then after that, it's just blood work once a week for the next 3 weeks. And then the good news is after that 5-week period, the person is then on the full dose of the drug, things are stable, and typically goes by much more smoothly after that. So usually once that first month is done, patients can do their blood work less often, maybe just once a month, for example. So there is a lot of work in monitoring involved during the first couple months of this treatment to make sure that everything goes by smoothly. But once you're done the first couple of months, it's pretty smooth sailing after that. So we've got two very good options, including BTK inhibitors and BCL2 inhibitors. They're both used very effectively for chronic lymphocytic leukemia, and they're also starting to be used in other cancers as well. So the question comes up with both of these medicines available, particularly for chronic lymphocytic leukemia, which one is the best treatment for me? Truthfully, they both have their pros and cons, and it depends on each situation, and it's something that your doctor would discuss with you. BTK inhibitors, they do tend to be quite convenient because they don't require any intravenous treatment, and they don't require all that blood work monitoring. So it definitely is a much easier to take for the patient, but the downside is they must be taken indefinitely over the long term, and they can cause side effects, particularly heart side effects in some cases. The BCL2 inhibitor, venetoclax, it does require more work during the first couple of months, especially to receive the intravenous treatments as well as to monitor all the blood work. But after the first couple of months, it's usually pretty easy after that. It doesn't cause as many side effects, particularly doesn't cause any side effects to the heart. And the nice advantage of the BCL2 inhibitors is that we can typically stop treatment after 1 year. So this can be a very nice option for someone who doesn't mind doing all the blood work during the first couple of months in order to gain a nice long time off treatment and not have to worry about taking a pill every day after the first year. So both can be great options. It depends on each situation, and we often do discuss the pros and cons of each approach for patients in a given situation. Another question comes up, if these two drugs work really well on their own, why don't we combine them together? So that's actually a very promising new combination called ibrutinib and venetoclax, or I plus V. And there are different versions of this protocol, but many of them start with 3 months of the ibrutinib, and that's given to shrink down the CLL. And then we start the venetoclax, by which point they're at very low risk of tumor lysis. And the two together can be given for a total of a year, or in some cases 2 years. We currently don't have access to the combination of the two treatments in Canada, but it is coming soon, and I expect you'll hear more about these during some of the talks tomorrow. Ibrutinib and venetoclax is probably soon going to be available in Canada for chronic lymphocytic leukemia as the first treatment. Perhaps in the future, it will also be available for mantle cell lymphoma because it's also a very promising combination for that disease. So the nice thing about this treatment is that it's all oral, it's only tablets, there's no intravenous treatment required, and it's also fixed duration, meaning patients only require 15 months or sometimes 2 years of treatment, and then they get to stop and enjoy a nice long remission without being on daily treatment. So stay tuned for that. We expect this will be available in Canada in the coming months for some diseases. So that brings us to our final class of targeted therapies for today. It's one that I'm particularly excited about, bispecific antibodies. So this is a very new treatment that's just become available across Canada over the past year, really. And it is a drug that's an antibody with it. It has two little arms. With one arm, it binds to a protein called CD20, which is a common protein expressed on the cancerous B cell. With the other arm, it binds to CD3, which is a common protein expressed on a patient's T cell. We all have T cells in our body, in our blood. They help to fight off infection. They also help to fight off cancer. But cancers often have ways of hiding from our T cells. So we need new tools and treatments to help make our T cells and our immune system more powerful to attack the cancer more effectively. So this antibody, with one arm, it brings the T cell right close to the cancer cell, and it helps the T cell to then attack and get rid of the cancer cell. So what makes these treatments so promising? They are entirely chemo-free. They really just use the immune system to treat cancer, and they've been shown to be quite effective even when other treatments haven't worked as well as hoped. What's really nice is that they're immediately available to patients. These drugs work similarly to CAR T cell therapy. Both treatments use the immune system or T cells to attack cancer, but CAR T cells require a manufacturing period to produce them. These bispecific antibodies are available in a vial right on the shelf, so we can give it immediately to patients without needing to worry about collecting T cells or manufacturing them. These treatments also tend to not cause too many side effects. Most people do very, very well without any major side effects. And as a result, we can often give these treatments in the outpatient clinic without having to hospitalize patients for very long, at least. And they can also be given in smaller hospitals or rural locations, which makes these treatments very accessible. So we currently have 2 bispecific antibodies which have been approved and are just starting to become funded across the different provinces for diffuse large B-cell lymphoma. One is called epcoritamab and the other is called glofitamab. They both seem to be quite fairly equally effective, and they both seem to also have a fairly similar side effect profile, but they do differ a little bit in how they're given. So epcoritamab is given as a quick injection under the skin. Glofitamab is given as an intravenous infusion, which is often as long as 4 hours during the first treatments and then as short as 2 hours later on. Epcoritamab tends to be given more frequently, and it's also given indefinitely, meaning the drug is continued for as long as it's working, unless some side effects occur that require the medicine to be stopped. Glofitamab is given less frequently, often just every 3 weeks, and it's also a fixed duration treatment, meaning that we typically give it for about 9 months, and then the patient gets to stop the treatment. This shows you a little bit in more detail how the drugs are given. So epcoritamab typically starts with a very small dose on day 1, and then a slightly bigger dose on day 8, and then we give the first full dose on day 15, and that slow dose increase is designed to help reduce the risk of side effects. The treatment is then given weekly for 3 months, and then it's given every 2 weeks for 6 months, and then it is given every 1 month after that for as long as the medicine is working. Glofitamab is a little bit different. First, we actually start with a dose of obinutuzumab, which is the same antibody that we combine with venetoclax for CLL, and that's designed to help reduce some of the side effects that can occur with this medicine. A week after that, we start with a baby dose of the glofitamab, and then there's an intermediate dose, and then a week after that, we give the first full dose of the drug, and then that is then repeated every 3 weeks for a total of about 9 months. What are the main side effects that we can see with bispecific antibodies? So the most important one to be aware of is something called cytokine release syndrome, or CRS. So this is sort of inflammation that can be released by the T cells as they attack the cancer. It typically occurs during the first few weeks when the dose of the drug is being increased, and it most commonly can cause a fever. So about half of patients don't get any inflammation at all, but half of them do. In most cases, it's just a fever and it goes away on its own in a day or two. But in some cases, the inflammation can become more severe and it can cause low blood pressure or low oxygen levels, or in very rare cases, it can even require ICU support to help resolve some of the inflammation. So it's usually during the first couple weeks of treatment when this occurs, and some patients may be hospitalized, especially after one of the doses that can cause cytokine release syndrome for 24 to 48 hours to monitor for some of the side effects. But usually once we've done the first month of treatment, the risk of this goes down. It's very rare to run into any of these side effects afterwards, and the rest of the treatment can all be done as an outpatient. Rarely, some patients may also experience neurologic toxicity when the inflammation can affect the brain, and that might cause a headache or dizziness or tremor or weakness. Um, Again, though, this is quite rare and usually mild, and in almost all cases, it does fully resolve. It's temporary. Over the long term, these medicines can cause immune suppression as well as sometimes low blood counts, so there can be an increased risk of infection that we have to monitor for over the long term. The inflammation is quite predictable in that it usually occurs during the first months. So with epcoritamab, most of the cytokine release syndrome occurs after that first full dose on day 15. So that's when many patients will be admitted to hospital for 24 hours just to monitor. With glofitamab, most of the cytokine release syndrome, if it happens, occurs on the dose on day 8. So that's the one that might be given in hospital for glofitamab, and oftentimes the rest of the treatment can be given as an outpatient. We do lots of careful monitoring and treatment to help prevent cytokine release syndrome. So we do step-up dosing. We start with a very small dose and then slowly increase it week by week until we get to the full dose. Patients also receive lots of pre-medications like Tylenol or steroids to help reduce inflammation. It's also important to drink lots of water and to stay well hydrated. And then with close monitoring and sometimes a brief hospitalization, we can usually get patients through that initial month of treatment quite smoothly. If patients do develop cytokine release syndrome and develop fevers or sometimes low blood pressure, we do have good treatments available. The most important treatment is time because usually the fevers and the inflammation will resolve on its own within a couple of days. But Tylenol can be very effective to help treat fevers. Tocilizumab is an antibody that helps to reduce inflammation, and steroids are also strong anti-inflammatories that can be very helpful in rare severe cases of cytokine release syndrome. So that brings us to the end of the presentation. In summary, we've seen a number of very exciting and promising new targeted therapies that have revolutionized the way that we treat many lymphomas, including chronic lymphocytic leukemia and mantle cell lymphoma and diffuse large B-cell lymphoma. These targeted therapies really target the cancer on a biological level. They tend to be more effective than chemotherapy, and they also tend to cause fewer or milder side effects than chemotherapy. But some of these drugs do cause unique side effects. We talked about the cardiac side effects with BTK inhibitors, or the risk of tumor lysis syndrome with BCL2 inhibitors, or the risk of cytokine release syndrome with bispecific antibodies. But usually with close monitoring and our preventative medications, we can help keep those side effects at a minimum. So thank you for your attention. I'd be happy to take any questions.
Thank you, Dr. Puckrin, for that overview in regards to targeted therapies. The landscape is quickly changing for lymphoma, and we always get a lot of patient inquiries wanting to know more about targeted therapy. So I think that was a great introduction. And with that said, just a reminder to the audience, if you do have questions, please be sure to enter it in the chat, and we'll try and answer as many as possible. So we have a few questions, one being that it seems like there's lots of targeted therapies now becoming available. How is it decided which therapy would be the best fit for a patient? For example, BTKis versus bispecific antibodies or even CAR T.
It does become challenging because we have so many different medicines now available for different diseases. But it all depends on what type of disease a person has and whether it's the first treatment or whether they've already received treatment and have a relapse. Different drugs have been tested in clinical trials in all of these different conditions, and then they get approved and funded across Canada for those specific indications. So it really does depend on what situation we're talking about. Typically, your doctor will go over what options are available with you at that particular time, as well as the pros and cons of each treatment, and then you can make a decision together about which one might be the best for you at that time.
Okay, and in relation to this question, for patients over 65, is there any preferred first treatment, or is that not enough information?
It depends on which treatment we're talking about. That question might be more for chronic lymphocytic leukemia, it sounds like. So for that situation, a person may have access to either a BTK inhibitor or a BCL2 inhibitor. A lot of it depends on the disease itself. You know, if there are certain high-risk genetic markers that might point you in one direction, It also depends on what other health conditions a person might have. If they have a history of heart problems, then they may want to avoid a BTK inhibitor and maybe start with the BCL2 inhibitor instead. But it also depends on where the person lives and what their mobility is like. In order to receive the BCL2 inhibitor, there are some intravenous treatments as well as frequent blood tests during the first couple of months. That might be difficult for someone who has limited mobility or who lives very far away from a cancer center, for example. So it all depends on each situation. And again, that's something that will be discussed with each patient, with their doctor, and then they can reach a good decision together.
Perfect. And can you contrast and compare between BiTEs and CAR T cell therapy?
So they're very similar treatments because they both use T cells to attack cancer. They do differ in some important ways, though. So CAR T cells, they do require that we actually extract the T cells from the blood. And there's about a 1-month manufacturing period to make the CAR T cells. They then are given back to the patient, and that typically requires about a 2-week stay in hospital to monitor for some of the side effects. And in general, the side effects with the CAR T cell treatment can be more severe. We can see more inflammation and more neurologic toxicity as well. Bispecific antibodies, they are a newer treatment. We don't yet know are they as effective as CAR T cells, but they do look to be promising. But they are definitely more easy to give and don't cause as many side effects. So bispecific antibodies, they're just drugs that are available right on the shelf. We can give them right away. There's no manufacturing period. In general, they don't require a long hospital stay, perhaps just 24 to 48 hours, but hopefully no longer than that. And the risk of side effects with the bispecific antibodies tends to be lower, but we still can see some fevers and cytokine release syndrome. The main thing with the bispecific antibodies is that they require ongoing treatment. So CAR T cells, it's the one-time treatment and then you're done. But bispecific antibodies require treatment every week or every few weeks for a prolonged period of time. So they each do come with their pros and cons.
Thank you for that comparison. And then the next question we have here is which patients can be treated with bivalent antibodies in Canada?
So right now, bispecific antibodies have been approved for diffuse large B-cell lymphoma, and they've been approved for the lymphoma if it has recurred after 2 prior treatments, like chemotherapy, for example. And it's only approved if a patient has either already received CAR T-cell therapy and the disease recurred, or if they're unable to receive CAR T-cell therapy. Perhaps they live too far away from a CAR T-cell treatment center, or they have other medical problems that might make the CAR T-cell treatment not safe for that patient. So right now, that's where we're starting to use bispecific antibodies, but they are being tested in many, many clinical trials, and they are showing a lot of promising activity in other lymphomas as well. So I expect over the next year or two, we're going to see these medicines being used quite commonly for other lymphomas in addition to diffuse large B-cell lymphoma.
Okay. And the next question is, if unmuted, would you ever consider BCL2 inhibitors for first-line treatment of CLL?
Yeah, I think both are actually quite good options for patients who have high-risk genetic features. Perhaps we have a little bit more experience with the BTK inhibitors for patients who have unmutated IGHV. But from the clinical trials, we know that venetoclax can also work very well for those patients, and it does provide patients with an opportunity to be off of treatment for many years. The reality is many patients can actually access both treatments over the course of their lifespan. So if a patient starts with venetoclax, they receive 1 year of treatment, they hopefully get a nice long remission that will last for several years. If and when the leukemia does come back again, they could potentially receive venetoclax again if it worked really well the first time, or they could then switch to the other drug, the BTK inhibitor at that time. So patients often can benefit from both treatments over the period of years as the disease might require treatment from time to time.
Perfect. And the last question for today, is there a preference for order? So trying bispecific before CAR T or vice versa?
It depends a little bit on each situation. CAR T cells have been around for longer. We have a little bit more experience with them. We know that they really can cure a good proportion of patients who have diffuse large B-cell lymphoma. So in general, many of us do try to prioritize CAR T cell treatment first. but it's not always an option for everyone. It does cause much stronger side effects. It requires being hospitalized. It may require traveling a long distance to a CAR T-cell treatment center. So for patients in which CAR T-cell therapy is not an option, or if they've already received CAR T-cells and they didn't work as well as hoped, in those situations, bispecific antibodies can be a very good choice.
Thank you, Dr. Puckrin, and thank you everyone for submitting questions. I will remind the audience that there will be plenty of opportunities to ask questions tomorrow as we're diving into the subtype specific sessions. There'll be a 30-minute Q&A for the various subtypes, so please be sure to tune in tomorrow and bring these questions there. With that said, I would like to direct the audience to attend the closing remarks for today, and I hope to see all of you tomorrow for day 2. Thank you.